about the normal puerperium. Today's topic is the complications which can happen. And if you go through the list of complications, most of the disorders is not peculiar to puerperium. These are the things possibly you have already come across with different other disciplines. So just to remind, just to recapitulate that these things are more prone, these things can happen, more risk of happening, these disorders are more in case of puerperium. That's why it has been discussed. After the puerperial period is over, then the complication, if it happens, same complications that will not be related to the puerperium. So number one is puerperial pyrexia, is nothing but fever, but as it is happening to the during puerperium, so it has got a special importance because it can cause maternal death. If the puerperial pyrexia is ignored, it could cause maternal death. Silence please. It could cause maternal death. Thromboembolism, that is also a disease. If you find with the patients who are more prone to have, that could cause also maternal death because of pulmonary embolism. And next is secondary PPH. So PPH, you know, occurs during delivery or just after delivery, but this is secondary PPH, and so after 24 hours by definition, possibly you know. And urinary complications, which is more prone to occur during puerperium, breast problem, and psychological disorder. So these are nothing special from psychological disorder, but puerperial mothers are more prone to have, and others we will discuss later. So pyrexia, there is a definition. All of you will be asked, because in long case a puerperial mother will be given. Every alternate student likely you will get as a long case. So you will be asked what do you mean by puerperial pyrexia? It is more than 100.4 degree Fahrenheit, persisting for more than 24 hours, excluding first 24 hours, within 2 weeks, somehow it is written 10 days of childbirth. Why 2 weeks or why 10 days? Because this is the period, 2 weeks the period during which genital tract recovers its epithelial surface. So chance of infection will be less after 2 weeks. So in that case, other causes of infection will be considered. So maximum chance of infection of the genital tract before the complete epithelialization occurs, that is 10 days to 2 weeks. So that's why it is definition. So causes may be genital tract sepsis or maybe sepsis at other sites. So genital tract sepsis as a cause of puerperial pyrexia, which has another name that is called puerperal sepsis. So puerperial pyrexia and puerperal sepsis is not the same. So puerperal pyrexia may be so many regions, but puerperal sepsis is one of them. So that is also asked often. The sepsis, you know, puerperial mothers are more prone to have sepsis because the epithelium surface is disrupted, and because the pH changes, and because the genital tract is open because of the following delivery, the cervix remains dilated, and so infection can easily go up along the tubes up to the peritoneum. So that's why is more prone to have, and pH also changes. You know, the defense mechanism of the infection of the genital tract is pH. That pH also changes following delivery. So organisms are maybe aerobic, maybe anaerobic. So beta, because this is to be considered during treatment. So you have to give antibiotics or give the agents, chemotherapeutic agents both against aerobic and against anaerobic. So you do not know which is the organism, so you have to treat both at the simultaneously. Beta hemolytic streptococcus is very common, group A also, Staphylococcus, E. coli and others. So pathogenic organisms, mostly pathogenic organisms in puerperal sepsis, not the PID. So PID, pathogenic, they are separate, not these things mostly. Anaerobic may be streptococcus, anaerobic streptococcus and bacteroids. So you know from your knowledge of bacteriology. And these organisms, the source is either iatrogenic, means exogenous, because we the caregivers during delivery have introduced the organism, and that has, we have inoculated the organism because of infected, contaminated instruments which are not properly sterilized, gloves also, if not properly sterilized, they will carry the organisms to the genital tract. So this is exogenous. This is discussed first because this is the place where you can take steps and 100% you can prevent the puerperal sepsis. So this is exogenous. And next is endogenous. You know, vagina and perineum is full of organisms. So infection may be inoculated from there, may be carried from there to upwards. So before doing any interference, the vagina should be cleaned and antiseptic dressing should be given, and perineum also, so that organisms is not carried, at least population of the organisms is reduced so that it is not carried upwards. So that way also, so these are the knowledge required for prevention of sepsis, puerperal sepsis. So exogenous and endogenous, these are the two sources. Whenever you will face some puerperal sepsis, so you have to think which was the reason, why the perineum vagina was cleaned properly, or whether the instruments and gloves was properly sterilized or not. Pathology, what happens? So infection usually lodges there, vagina, cervix or endometrium. So if you pass your hands to the endometrium like manual removal of placenta, or you can putting some instrument in the endometrium, so you can directly carry the organism to the endometrium. Or usually, so vagina you cannot avoid the manipulation during delivery, and cervix also. Cervix is the area where the infection can easily be lodged. So vagina and cervix, because the loss of defense mechanism, that means laceration during childbirth, change of pH, and so small hematoma may be there. So because of these reasons, infections, organisms can easily lodge there and grow. So that is a very favorable, the media is very favorable for growth of the organism. So not only the infection is carried, but they will grow. So following that, this infection may be carried up. Ascending infection of the uterus, so from the cervix it moves up. So uterus, that is called endometritis, and then tubes, salpingitis. In this case, salpingitis is perisalpingitis or interstitial part of the tube. Not the endosalpingitis is not common. So pathogenic organisms affects the endosalpinx purely, which happens in gonococcus and chlamydia. Pelvic peritoneum from tubes, if it can further travels, it will reach the pelvic peritoneum. So pelvic peritonitis, so lower abdominal pain, and from pelvic peritoneum, it can reach the general peritoneum. So general peritonitis, from there it can reach the circulation, so causing septicemia. So see, the infection which was lost in the vagina and cervix, it is because of our carelessness, because it was not detected early and because it was not treated early, so it will reach the peritoneum and blood. So that is septicemia, which will lead to multi-organ failure, so that is equal to death of the woman. So following a delivery, because of just the proper aseptic precautions were not taken, it can lead to the death of the mother, or the proper early care was not taken. So endometritis, salpingitis, pelvic peritonitis, abscess. So pelvic abscess can also occur, and general peritonitis, abscess can rupture or without rupture, general peritonitis, and septicemia. Septicemia, that means infection within the blood. The organisms are growing, flourishing within the blood. So by that it can reach the many vital organs. So that is the pathology of puerperal sepsis. It can spread by lymphatic also. So not only direct ascending infection, it can easily spread by the lymphatic to parametrium. So that we will call parametritis from their pelvic abscess also, and it can affect the veins at the placental site. Infection can very easily lose of the thrombosed veins. So from that veins, from the placental veins, it will reach the pelvic veins, and pelvic veins to ovarian veins or iliofemoral veins. So and from the ovarian veins, it can reach the vena cava. So organisms in case of genital tract sepsis can easily reach the blood, which does not happen in other infections. Other common site of infection usually does not reach the blood. So by venous spread, it can cause septicemia or some other things which will come later on. So how to know? By checkup, by your clinical examination, that patient is suffering from puerperal sepsis. So number one is fever. So if the patient comes with fever, it should not be neglected following delivery. Number two is foul smelling discharge. So at the time when there is vaginitis, there is cervicitis, even endometritis, it will cause some bleeding and foul smelling discharge. So fever with foul smelling discharge, so one must think of, or 99% cases, it is due to local sepsis of the genital tract. And pelvic pain, by that time it has reached the either parametritis or pelvic peritonitis. So in that case, uterus is affected. From endometritis it is parametritis, it is called pelvic pain. So pain, fever and foul smelling discharge, these are the three things which are very important to know that patient is suffering from genital tract sepsis, or in the other name is puerperal sepsis. And on examination, you see subinvolution. You know, subinvolution means uterus reduction of fundal height occurs 1/2 inch per day. So by 7 days time, if you find fever is there and there is subinvolution, by that you know that the metritis or parametritis is there. The infection which is causing edema, so there is proper involution is not occurring. An infection which is inhibiting the proteolytic enzyme to act, so involution is not proper. So there will be so many causes of subinvolution, but first thing, the sepsis of the uterus or parametritis or metritis must be excluded. So in that case, uterus will be tender. So subinvolution is there, but uterus is not tender. That is not due to metritis or pelvic infection. Tender uterus. Muscle guard, so local muscle will be rigid, and of course there will be tenderness at the lower abdomen. So subinvolution, tender uterus, tender lower abdomen and muscle guard and pain, these are the signs of pelvic peritonitis. And per vaginal examination always be done, and our experience is in so many cases to exclude the forgotten swab. This is another place where our negligence is revealed. Our negligence is revealed. Forgotten swab, and it is of medical legal importance. If it is reported, you will be pinned, you will be that your negligence will be proved, because during the repair of episiotomy, often we put a swab to prevent the blood offending our site of repair. So that is that swab we have forgotten to take it out after finishing the repair. So that is the cause, and that must be excluded by your PV examination. Other than that, by PV examination means reveal so many things. It may reveal some tear which was not repaired and infected, and you will see the vagina is inflamed and red, so, and the foul smelling discharge will be, of course, will be there. So foul smelling discharge, the offensive smell is such that even the family men will report it, that doctors, we are getting the offensive smell from her. So that is the time you have to pick up the patient for genital tract because of genital tract sepsis. So investigation to be done is high vaginal swab. It is likely that from the vagina or from the cervical swab, from the cervix, the infection is going up. So from that you can, by culture, you can isolate the organism, and according to sensitivity, you can treat the patient. So send for culture and sensitivity, high vaginal swab. That is a very much important organization. Other investigations, of course, if it is found to be septicemia, blood culture is to be sent also, or other places, other investigations to be done to exclude the infection at other sites. And ultrasonography is a must. Ultrasonography, because to exclude any retained product, which is a good media for growth of the organisms. Placental tissue is dead following delivery, so any infection, if it is carried there, so it will grow and it will cause genital tract sepsis. So ultrasonography must be done to see any retained product, not only sepsis, but at some time that retained product will be separated and will cause PPH. So ultrasonography is a must to see and not only the retained product, but in the pelvis also it will be able to reveal any collection and other things. So ultrasonography to see any retained product and collection of pus, it will be revealed by the USG, so we can drain the pus under ultrasound. So coming to the treatment part, so number one is exclude foreign body. Even after vaginal delivery, but even if it occurs after cesarean section, in that case the situation is grave, because in that case foreign body is forgotten within the abdomen. So in that case USG or CT scan is required to exclude any foreign body within the abdomen, and there is no other way than to remove it by another laparotomy. So exclude foreign body is everywhere because it has got a medical legal importance. Patient will ask for the compensation because of your act, of your negligence. So antibiotic definitely both against aerobic and anaerobic organism, usually gentamicin, ampicillin and metrogyl. These are the three combinations we usually give during our empirical treatment before the culture sensitivity report comes. So if the report shows any other sensitivity, then we can change, but before that gentamicin, ampicillin or ampicloxus, your clavulanic acid plus metrogyl, metroriazole is the drug against the anaerobic infection. So antibiotic is to be given oral or antibiotic, oral or injectable, decided by the severity of the conditions. So surgery, place of surgery, it is for the retained product. So D and C, you can remove retained product from the uterus of definitely after antibiotic cover for more than 24 hours. So 24 to 48 hours cover of antibiotic, after that you remove, you go for surgical intervention. Otherwise, these organisms will be disseminated and will enter the circulation and will flourish the more infection. So under antibiotic cover, you can go for surgery. Drainage of abscess, of course, can be done through the colpotomy incision, posterior pharynx, where the pouch of Douglas is there. So under ultrasonic guidance or just without guidance, even if you put a needle into the pouch of Douglas, the abscess will be detected, but you have to give incision on the pouch of Douglas for drainage, for free drainage. Then laparotomy in cases of especially following cesarean section or following normal delivery also, because if not responding because by USD you will be able to see some loculi are there, collection of pus within the abdomen. Those are the things which will not respond, where the antibiotics cannot reach there. So unless they are drained by some other ways, the patient will not be improved. So laparotomy is needed ultimately if after 5 to 7 days of antibiotic, patient fails to respond, fever still persisting. So laparotomy to drain the pus is very important. So laparotomy. So prevention of sepsis. So already I have discussed all sorts of antiseptic, aseptic precautions. WHO has given 6 cleans to be observed at labor. That means we are coming to that 6 cleans. You know that clean surface, clean perineum, clean cut, and clean hands. So these are the few cleans which we observed during labor. Sterile vulval pad. This is very important. It is often not supplied in government hospital even. These are the source of infection. So if the vulval, VUL, so vulval pad, if it's contaminated, it is not properly, if it is not sterile. So pad available at the shop is not sterile. You have to take the shop and you have to make sterile by autoclaving in the hospital. So this cannot be supplied at home. So this is supplied at the hospital, a sterile vulval pad from where the organism can go up. That is very important. And early detection and treatment to prevent septicemia. That is the step to prevent the death of the mother, to reduce maternal mortality. Early detection and treatment to prevent septicemia. So usually we ask the mother to come for follow-up after 6 weeks during puerperium, but these are the things, if the mother complains of so many symptoms like this, mother should come before, so that we do not miss the puerperal sepsis is not missed. So prevention, I had already discussed risk factors. So what are the risk factors which are causing sepsis? So repeated vaginal examination, that should be avoided, especially if the membrane is ruptured. So in that case, the organisms, because of the ruptured membrane, organisms can go up. Or following prolonged rupture of the membrane, there will be chorioabdominitis. That means infection within the uterus. So repeated vaginal examination to be avoided. Prolonged rupture of membrane is one of the cause. So, and instrumental deliveries. So if you do the forceps deliveries or the venous deliveries, in that case, manipulation of the vagina, laceration of the vagina is much, so chance of infection is also increased. So these are to be avoided. So unless it is required, and observation of 5 cleans or 6 cleans, clean surface, clean hands, clean cord, clean perineum, and clean tie. So that's the way of preventing puerperal sepsis. Then that is about puerperal sepsis that I have discussed. But what happens to the puerperal pyrexia? So patient is coming with the pyrexia, 100.4 degree Fahrenheit temperature after 24 hours. Why after 24 hours? Because during 24 hours, there will be reactionary rise of temperature because of so many reasons, because of labor, because of IV fluid and all those things. So that's why we exclude first 24 hours. And urine for culture and sensitivity. So what are the other causes of fever that you have to exclude in case of puerperal pyrexia? If it is not puerperal sepsis, then we have to take the help of the physicians or medical colleague. So in that case, our first possibility is urine infection. So urine for culture and sensitivity to be sent. So maybe not the cystitis, it is pyelonephritis. Cystitis does not cause usually fever. So pyelonephritis means for ascending infection. Culture and sensitivity is to be sent because the risk is more because we often catheterize during labor or following delivery because of retention of urine. So that is the cause. If the catheterization is not done properly, if during that you can carry the infection in the proximal urethra upwards. So that's why catheterization or the catheter is not properly sterilized or during insertion it does not maintain the aseptic conditions of the catheter. So in that case catheterization itself could cause urinary infection, cause of puerperal pyrexia. X-ray chest, that is also very important. Number one, tuberculosis is a condition which can flare up during puerperium. So fever with antibiotic not responding, so we should keep it in our mind that tuberculosis is a possibility, especially in our country. Poor mothers, poor hygienic, poor residing conditions, tuberculosis is a possibility. And number two, because of the prolonged lying condition following cesarean section or during labor, 10 hours, 15 hours during labor, so that could cause pneumonia. So, or some other reasons, patient was advised prolonged rest during pregnancy, followed by there was labor. So, because of the prolonged lying down condition, there may be pneumonia, possibility is there. So, X-ray chest should be done to exclude pneumonia and blood for fever profile, that you know from the physician's advice, all the things including malaria and often we face leptospira. So leptospira, everything we are getting is coming, presenting during the puerperium. So these are all medical problems of fever, medical causes of fever that we have to exclude for a case of puerperal pyrexia as directed by the physicians. So investigations of puerperal pyrexia, we must keep in mind the tuberculosis or pneumonia and urine culture must be excluded. Then you come after infection, then is our secondary PPH. This infection of the uterus, that means endometritis, can cause secondary PPH, especially if it is associated with retained placenta. So retained placenta and infection of the uterus come hand in hand. So if you treat one, the other will be automatically treated. So if you treat the retained placenta, the focus of infection is removed, so endometritis will be, PPH will be cured. So PPH, secondary PPH means PPH after 24 hours. Cause is endometritis, number one. Number two is retained bleed of placenta. So that goes hand in hand. And then is undiagnosed infected vaginal tear. Vaginal tear which was missed, which was not detected because it was not bleeding, so it was not repaired. So because it is tear not repaired, so that will be infected. Once it is infected, so tissue becomes friable and vascular, so that will give, sloughing out of that will give rise to the bleeding. So we have number of times we have faced the cause of bleeding is undetected infected vaginal tear. So these are the three important causes: retained bits of placenta and undiagnosed infected vaginal tear and endometritis. So treatment is accordingly, so only antibiotic or surgically remove the bits, or in that case the repairs could not be done at the same time. After you treat the infection, the tissue becomes healthy, then you can only go for the repair. So before that, to stop the bleeding, you have to use pack. So local pack is to be given to stop the bleeding if it is found to be due to infected vaginal tear. So pack will be effective. But pack against, if you keep it for longer time, so it will cause invite infections. Retained product has to be excluded by ultrasonography in case of secondary PPH. Retained placenta, retained product has to be excluded by ultrasonography. So ultrasonography is a very important investigations in case of secondary PPH. So, and retained product or retained bits of placenta is you have to, that is to be excluded at the labor room by examining the placenta, fetal, your maternal surface of the placenta. If you find any missed cotyledon, so at that time during at the labor room you can detect the retained bits of placenta. So if it is not done properly, then it will cause the problem, and ultrasonography can detect later on. So usually these PPH are not severe because this is not atonic, because in these cases, in case of eaten pleats, some of the bits are infected and sloughed out, causes a bouts of bleeding, then again few days gone, again infection, again sloughed out, so bouts of bleeding, recurrent bouts of bleeding. So not severe because it is not a atonic PPH. So usually not severe, but if the patient suffers for a long time, it will give rise to severe anemia. So antibiotic is a treatment, but a retained bleeds needs the surgical removal. So choriocarcinoma should be kept in mind. In the choriocarcinoma, you know, usually happens following molar pregnancy, but it can also occur in 20% cases following term delivery. So term delivery choriocarcinoma should be kept in mind. So instead of all these things, you find no cause, so in that case choriocarcinoma is to be excluded. So if you go for beta HCG estimation, that will be very high, but if it is a placental site trophoblastic tumor, beta HCG will be also low. In that case, D and C diagnostic curettes will only give a clue that this is a case of placental site trophoblastic tumor. So choriocarcinoma should be excluded in case of secondary PPH, especially if it is occurring after 3 weeks time. So recurrent bits of bleeding. Then you come to venous complication. Venous complication, you see, this is nothing separate from the thromboembolism you have gone through in the other subjects, which is in surgery. So in our in cases in puerperium, it is practically either a deep vein thrombosis in the leg veins. So either it is popliteal veins or it is iliofemoral veins. Popliteal, iliofemoral, the chance is more during puerperium. That's why we deal with, because of this stasis occurs during labor. It is not because of prolonged bed rest advised during pregnancy and during puerperium. So and because of the trauma, this is trauma and stasis, these are the two important factors for thrombosis. Because of the trauma of the popliteal veins by the leg stirrup, so we support the legs, mother's leg on the during delivery table, so that causes the trauma, or iliac veins during cesarean section, because of the traction, iliac veins may be damaged. So this trauma, stasis, and will lead to, and because of hypercoagulability during pregnancy, which is persisting for another 2 weeks during puerperium. So these are the three important things. So stasis, trauma, and the hypercoagulability. These are the things which causes risk factors for deep vein thrombosis. So on examination of the puerperal mother, if you find the edema leg, especially unilateral, so deep vein thrombosis, if it is both the side cannot occur at the same time, unless the common, even not, unless the common iliac vein is involved. But unilateral edema leg, usually iliofemoral vein if it is involved, unilateral or popliteal vein of one side, unilateral edema leg, pain of the leg, and inability to move. These are the symptoms of deep vein thrombosis. And on examination, you examine the omen or cuff tenderness. So pressing the cuff, that is the dorsiflexion of the foot, that is Homan sign, will be positive. So that is, you suspect that deep vein thrombosis, and of course in that case you have to advise, you have to go for Doppler USG of leg veins, which will prove that yes, it is due to thrombosis is there. So thrombus will be detected by the echogenic mass and reduced blood flow of the veins, and compressibility will not be there. So in a flowing veins, you can compress the veins by USG, but that will be negative if there is deep vein thrombosis and venous flow is obstructed. So Doppler USG can detect that the problem, the risk of thrombosis is not due to the edema or pain, but because of risk of dislodgement, detachment of the thrombus, and which will be arrested in the lung, causing pulmonary embolism. That's why the thing is discussed. And pulmonary embolism mortality is 50%, more than 50%. You will not be able to do anything. So patient will die if you don't take care during the edema and inability to move, edema, leg pain. At this stage, if you fail to take care, the thrombus will be dislodged from the veins and will cause pulmonary embolism. Risk factor is already I have mentioned: trauma to vein by stirrup, stasis due to immobility, hyperactivity, and risk is pulmonary embolism. So this is one venous complication, and risk is next is septic vein thrombophlebitis. In this case, that is also, you can say it is a puerperal sepsis, but because in this case the vein is directly involved, the thrombosed veins, so thrombus is infected. So thrombus within the vein is infected. So septic pelvic thrombophlebitis. So pelvic vein is thrombus and infected pelvic veins are there. So that can extend into the, as I already mentioned, into the either the ovarian veins up to inferior vena cava or the iliofemoral veins. If the starts at placental site thrombosed veins, so that is a easily site which is accessible to the bacteria, and recurrent, so manifested by recurrent spiky fever. So spiky, in this case what happens, the infected thrombi is dislodged and causes lot of organisms, releases lot of organisms in the blood, causing fever. Again after a few days or 2 days after or 3 days after, again there is dislodgement of the infected thrombi, again spiky fever. So bacteria, organism is growing within the thrombus. So antibiotic is not working, it fails to reach the thrombus. So unless the extension of thrombus is prevented, the fever will not subside. So so that is the problem. So recurrent spiky fever. So on examination, tender pelvic mass is palpable. This is nothing separate from the pelvic infection. So pelvic mass which is tender and on not responding to antibiotic, but on CT MRI only can detect the pelvic vein thrombosis. So if you suspect, it is not a case of pelvic infection because it is not responding to antibiotic. So you have to go for CT MRI of the pelvis, which can detect the pelvic vein thrombus, and you start heparin or LMW, low molecular weight enoxaparin. So that can prevent the thrombus from extension, further thrombus formation, and so that will cure the fever. So septic vein thrombophlebitis is a cause of recurrent spiky fever. Whenever you suspect that in spite of giving antibiotic, it is not responding, then you suspect it is possibly the thromboseptic pelvic vein thrombophlebitis. Then come to the urinary retention. You see, the bladder, gut, because of the progesterone effect of pregnancy, so every organs become to some extent relaxed, or atonic because of the progesterone effect. And that effect persists for several days, weeks. So in that case, the bladder will fail to contract. So that will cause atonicity of the bladder, and along with painful wound at the perineum because of the episiotomy, patient cannot give proper strain, so, and bruising at the bladder neck or edema. So all together, atonicity, bruising and painful wound at perineum all together will cause retention of urine during puerperium. So in that case, the atonicity of bladder is there. So catheterization for a week. So it will help, because not only the patient, the drainage of bladder will be done, but because the bladder remains contracted, it may regain its tone. It regains its tone, and after 1 week, you can gradually, before removing the catheter, you have to repeatedly clamp the catheter and release, so that bladder training occurs. And whenever you find after clamping the catheter, patient to able to feel the fullness of the bladder, that is the time you know it is the retention of urine in puerperium. Incontinence. So incontinence, two types of incontinence can occur following delivery. One is stress incontinence, because of bladder neck, there is alteration of the angulation. So up to that will persist for 3 months. So that will persist up to 3 months, and gradually when the pelvic trauma, pelvic injury will recover, the levator ani will regain its tonicity, and the proper continence will be regained. So up to 3 months it can persist. The stress incontinence means involuntary leakage of urine during straining, that is called stress incontinence. So it is not to be treated up to 3 months. After that, if it persists, then you can go for treatment. That is, stress incontinence up to 3 months is not abnormal. Then come to the true incontinence, means true leakage of urine, that is due to vesico-vaginal fistula, and that is possibly the bladder base is sloughed off because of pressure of the bladder wall against the symphysis pubis during delivery. The bladder base is compressed in between the symphysis pubis and the fetal head, leading to ischemia of the bladder, and ischemia leads to necrosis, so it takes time. So it is usually manifested on 10th day of puerperium. So initially there was no bladder leakage, but after 10 days you find the patient is coming with leakage of urine, that is true incontinence, so ischemic necrosis, and due to obstructed labor, especially when there was a prolonged labor or obstructed labor, so repair to be done after 3 months, not within 3 months, because it was ischemic necrosis. You have to give time to regain the vascularity of the bladder wall, otherwise the repair will be failed. So ischemic necrosis, so repair to be done after 3 months. Cystitis also, chance is there because of especially the improper catheterization, not catheterization done not aseptically, so repeated catheterization and retention. These are the two things predisposes to infection, cystitis. Aseptic care can reduce it, proper antibiotic is the cure. Psychiatric disorder, these are also nothing separate, but puerperal blues is a thing which is to be mentioned, because it is anxiety and stress about the rearing of the baby. So mother, following delivery, mother will face a separate situation. So she has to take the care of the baby. At the same time, she may have to take the care of the family. That's why, especially who has less support from family, if the family support is good, then this type of anxiety and stress disorder usually manifested during first week and spontaneously resolves. So if the assurance and support is proper, so these things will be solved, so this will not persist. But depression after second week, so because of the stress, if the stress is not revealed, and especially where the background of psychiatric problem was there, especially in the family, that will be manifested unmasked during the pregnancy, is a stress situation, and the depression, because the lack of appetite, insomnia, and lack of interest in the surroundings, lack of pleasure, so not contraindicated. So antidepressant drugs will be given, not contraindicated in breastfeeding, and respond to antidepressant. So depression you have to detect and treat it, otherwise it can cause harm to the baby. So harm to the baby, that's why we have to deal with, because not only she will cause harm to herself, but she will cause, instead of taking care of the baby, she can cause harm to the baby. That's why important these disorders has to be dealt with, and she is to be dealt in a separate ward where mother and baby can be taken care. Psychosis, frank psychosis is not uncommon following delivery, especially after within 2 weeks having past depression. So they are the patients who have suffered depression, possibly drug was withdrawn during pregnancy or something else. So restlessness, neglecting child, delusions, hallucinations, all will be there in psychosis, and antipsychotic drug is to be prescribed, and mother is to be admitted in a separate ward, not at the same ward. So psychiatric referral is a must. Complication in the breast, so you see engorgement of the breast, cracked nipple, mastitis and abscess, inadequate milk production. 4 important things of the breast. So these are all you will be asked if the puerperal is given as a long case. So engorged breast, you see the breast becomes tensed, painful, prominent veins there, usually on the 3rd or 4th day, because the lactation starts on those days. So lack of suckling, if the baby is premature, not able to suck, or baby is sick, or baby expired. So in those cases, you will face the situation of engorgement of the breast. The usual treatment is supposed to breast. If the breast is not, milk is not expressed automatically by break pressure of the milk, the milk secretion will be inhibited. So support of the breast, and analgesics for pain, and expression of the milk if the baby is alive. If the baby is not alive, expression of milk should not be there. Expression of the milk by breast pump, and milk suppression by cabergoline if the baby is not there. So that is the treatment of engorged breast. Then the cracked nipple, pain at the nipple area. So due to fissure at the base of the nipple, the cause is lack of cleanliness, just like crack heel, and improper attachment. So in this case, baby is sucking not properly. Baby is sucking with too much force because the proper placement of the nipple to the baby's mouth is not there. So that should be taught to the mother. That can cause cracked nipple. So cleaning is number 1, very important, with soap and application of emollient. So many emollients are available, maybe antiseptic ointment also. So, and if it fails to heal, so you have to withhold breastfeeding, because repeated suckling means repeated trauma, it will not heal. So withhold breastfeeding for 24 hours if not healed. Acute mastitis is another condition because of the cracked nipple or maybe without cracked nipple. The organisms, if proper aseptic precautions are not taken during the breastfeeding, so the organisms may gain entry into the breast via the milk duct or via the crack into the breast parenchyma, causing mastitis. That means it will pain, induration at the breast, redness and fever. These are the important symptoms of the acute mastitis, and cause is Staph aureus and streptococcus. So if it is Staph aureus, because it is coagulase positive response, usually we give co-amoxiclav, either injectable or oral. And so even if it is breast abscess, you have to give antibiotic. After giving antibiotic, the mastitis will be localized. Then if it is not resolved, you can go for drainage. So the complication is breast abscess. If not resolved, it is breast abscess, and in that case, drainage is to be done. Those swollen edematous red and dairy on breast and fever is not responding. So drainage by radial incision, because if you give the transverse incision, the lacteal duct will be injured. So that's it, to prevent duct injury, lacteal duct injury. So you have to give, so it will be taught in the surgery more details. And neurological complication may also be there. So food drop you can face following delivery. On the next day, patient is limping or unable to place her foot, move her foot. So injury of the popliteal nerve by the stirrup of the leg. So foot drop due to pressure effect by stirrup, that is stretching of the lumbosacral plexus is another cause during labor. So legs are supported by splint as a treatment. Physiotherapy is to be done for the paralyzed foot, and recovery usually occurs within 3 months. So if there is foot drop, you know this is temporary and it will be recovered. Sheehan syndrome, possibly you know from your physiological knowledge, that is ischemic necrosis of pituitary. Pituitary is very much vulnerable to ischemic necrosis following delivery, because it becomes so vascular that if there is hypotension, it undergoes necrosis. Because so following PPH and shock, because of the hypotension, the vascular pituitary undergoes ischemia and necrosis occurs, leading to panhypopituitarism. That means thyroid hormone, ACTH, prolactin, all are deficient in secretion. So deficiency of all these hormones leads to lactational failure because of the prolactin, and hypotension, hypothyroidism. Because of the ACTH less, so steroid hormone is less, so hypotension is there. So hypotension, in spite of correcting everything, that will lead to the thinking that possibly Sheehan syndrome, especially there is lactational failure which is not responding to anything, and she may present with lactational failure and amenorrhea because of this panhypopituitarism. FSH will also be less. And peripartum cardiomyopathy, this is actually the cardiomyopathy which may occur up to 5 months after delivery. So we have seen so many cases following delivery, some cardiac problems, cardiac arrhythmia and cardiac failure. So that is related to pregnancy. Usually patient was no cardiac diseases were found during pregnancy, but suddenly patient some cardiac diseases occurs at the last month or following delivery. That is called peripartum cardiomyopathy. That is a disease, and no cardiac disease during pregnancy. So it will dealt with by the cardiologist. And thank you. Thank you again.